Well, morning to you all. I see that most of you are on mute, which is probably wise for now, just to keep feedback down. But welcome, and we'll just give it a little bit, maybe another half a minute or so, and then we'll get cracking. I do hope you're all well. I've just been chatting to Luke, who tells me that he used to work at Lyons Davidson, and you may well know Luke very well. So he'll be talking to you in just a little bit. Let's see, I think I've got 11 o'clock on my clock here, so we'll make a start. We're delighted to be talking to you this morning. I'm Richard Wheeler, barrister of 16 years call at 3PB, specialising in personal injury, clinical negligence, inquests and costs. I act on behalf of claimants and defendants in fairly equal measure. I also sit as a deputy district judge in civil and as a recorder in family on the Southeastern Circuit. And in a moment, I'll be talking to you about expert evidence. And then you'll hear from Luke. Luke is a barrister at 3PB of 13 years call and also specialises in personal injury and clinical negligence. He also sits as a deputy district judge and as a judge of the first tier tribunal. And he's going to talk about chronic regional pain syndrome. We have notes to the talks. The PowerPoint notes will come to you afterwards. Luke's put together some further reading, and there's also a short paper which makes all the relevant points, which I've put together on experts. So you'll have that after the talk, and you don't hopefully need to feel that you need to make too many notes during the talk. The Q&A, or rather chat function of Zoom is quite useful. And in a moment, I'm going to ask you to turn that on and to join me in a very short and pretty easy quiz, just really to break down the barriers of social distancing and make it a little bit more interactive at the start, and also just to get you on the chat so that you can, if you want to ask anything, then do, and I probably won't break off from talking, but I'll have a look at them at the end and try and answer any questions. It's also, as Dave Snook, the clerk who's on the call, points out, it's also a very good forum for general abuse, but try to keep that to a minimum if you can. So let's just make a start and get going with a little quiz. I'm going to put up on the screen a word which is an expert, type of medical expert. I've taken the vowels out of the word, so it's going to be fastest finger first. Whoever can guess what the word is, put the answer in the chat. We'll see your name, and there are absolutely no prizes at all, I'm afraid, but you will get the plaudits of being the first person. So get ready on your keyboard, turn your chat on, and we'll get ready for that. And here's the first one. So that is a medical expert. I'm hopeful that I will see answers appearing in the chat on my screen. I've not seen anything yet. Brilliant. It's working. We've got Michael Bradbury, who takes the prize. So well done to you, Michael. Here's the next one. I've even got clues in case you were really sleepy this morning. But the answer is neurologist. And here's the next one. So let's see if Michael beats everybody to it again, or if there's anyone else listening. And you thought you were all going to sit there and do your emails while I was talking, and now I'm asking questions to you. Here we go. Kim, well done, orthopedic surgeon. Congratulations. We'll do a couple more. Here's slightly trickier. I'll put the clue up in a moment if I don't see anything. I told Dave that he wasn't allowed to take part because he knew the answers. But if you want to, Dave, brilliant. No, you've been beaten to it. Rebecca, well done, ENT surgeon. And the final one. let's see if one more person we get a different name on the screen. Meryl, well done. Psychiatrist, not quite. Psychotherapist. So there we go. A little bit of warm up, and well done. And now let's have a look at the body of what I'm going to talk to you about. I've broken it down into 5 areas: selection of the experts, experts' duties, the expert report, identifying weaknesses either in your own expert's report or that of the other side, and a remedy for those weaknesses with your own expert. So some of this, I hope, will also draw on some real life examples or slightly anonymized examples. I spent 2.5 years on the Kenya Mau Mau litigation, 40,000 claimants suing the Foreign and Commonwealth Office for compensation arising out of torture and human rights abuses in Kenya in the 1950s. And a large part of that case was spent trying to destroy experts. So this talk draws on experience on that case. And some of the examples are, well, I've changed obviously the facts and everything, but it draws on some of those points. So let's have a look at selection of an expert. Of course, you know that the principal question is an expert reasonably required? And in personal injury and clinical negligence claims, that probably it usually doesn't trouble the court. It's usually pretty obvious that an expert is required, but it's helpful to just remind ourselves, perhaps where there's the more esoteric areas or the other side wants an expert and you think that either the person that's being proposed is wholly wrong or inadequate for the purpose, then these are the helpful things to remember from Kennedy and Cordia services. The questions are whether the proposed evidence will assist the court in its task. And that's really absolutely key when you're sitting from the judge's point of view. Is this going to help? Because if it isn't, then we don't need it, potentially. Does the person being suggested have the necessary knowledge and experience? Are they impartial? Is there a reliable body of knowledge to underpin their evidence? Well, usually, of course, in medical fields, there's no problem with that. But then what about accident reconstruction or other more unusual areas? These points that are on here are useful to have in mind in terms of analysing your own expert, the proposed expert that you might want to use, but also when you're looking to undermine the other side's expert. You're always going to be looking at whether the expert has got the necessary knowledge and experience. If you can find that there's an element of impartiality or some sort of conflict of interest, then that's going to be useful in undermining your opponent's expert. Now, in terms of a little bit of detail on selecting an expert, still in practice, absolutely key in my view, that the person has relevant experience, that they're at the coalface, that they're still practicing. And my experience, and in recent days, unfortunately, has been that when you're dealing with experts that are no longer in practice, you really feel your heart sink when you talk to them. I mean, this may not go for all of them, but I have had some recent experience where it was just pretty clear that the lines of cross-examination, if the case ended up at trial, were going to undermine this poor gentleman, simply because he hadn't really practiced for a fairly significant amount of time, and he was going to be exposed, in my view. He also didn't have quite the not only the level of current knowledge, but really the sharpness, I felt, of mind in answering questions, possibly because he was in retirement and spent his time writing medico-legal reports rather than actually practicing. And picking out a couple of other points from here, one's looking with experts for a balance in whom they act for, whom they appear for, and I've mentioned conflict of interest. In bigger cases, it's always worth looking to see whether experts have been criticised in any cases or any other professional context, because those are the sorts of lines of inquiry that you can be sure your opponent will be making. So let's move on to take an example. Here's an example CV which cropped up in a recent case. And it said, I'm a registered medical practitioner in full-time practice for over 20 years. I've been a consultant in emergency medicine for 25 years. Now, this expert was used to give an opinion, amongst other things, about osteoarthritis. And the expert concluded for the claimant that the osteoarthritis had been caused by the accident. The first line of attack from the defendant's point of view at trial was to undermine their expertise. And here we're going to call upon Mr. Ashby, who is the eminent expert and is going to play the expert in the short bit of cross-examination to see how this unfolds. Now, Luke, could you unmute yourself? Well done. So we're in court now, Luke. Mr. Ashby, your expertise, built up over many years, is in the field of accident and emergency medicine. Is that correct?
Yes.
As a general proposition, would you agree that accident and emergency medicine is concerned with the immediate consequences of trauma or illness?
Yes, it is.
And that as a general rule, one doesn't follow up patients in the longer term, but passes them on to the specific disciplines that specialize in those conditions. Unless, of course, it's a condition that can be treated perhaps once in A&E and then sent home.
That's correct, yes.
In that regard, whilst you have enormous experience of dealing with the immediate orthopedic consequences of an accident, your personal experience of following up those patients is small or non-existent. Is that correct?
You are absolutely right to say that A&E emergency medicine deals with the immediate consequences of trauma and illness. Of course, we see patients who have long-standing conditions who come to A&E. They come to the emergency department, and I'm familiar with the general principles of the progression of a range of conditions, both orthopedic and other conditions, which I see in my day-to-day practice.
Yes. Just to be clear, you would not usually treat patients with chronic conditions, such as osteoarthritis in the hip. They may attend A&E if there's a sudden onset of pain or an increase in pain, such that their first port of call is A&E, but they would be referred on to the orthopedic department.
That's correct.
All right. Well, thank you very much, Mr. Ashby. Those are my questions for you. Well, I'll leave it to you to form a view as to how effective that line of cross-examination was. But you can see that the defendant in that case is trying to expose weaknesses in the claimant's evidence by undermining the expert that they've used to offer a central proposition of their case. Now, we'll move on to have a look at the duties of an expert. And practice direction part 35, of course, will be very familiar to you. It sets out therein a number of duties, for example, giving details of qualifications, details of literature relied on in the report, and so on. But I want to focus on a couple of key ones. A duty to make clear which of the facts stated in the report are within the expert's own knowledge, and the duty that where there is a range of opinion on the matters dealt with in the report, to summarize the range of opinion and give reasons for the expert's own opinion. And these two, I would suggest, are two of the keys. And it comes to looking at the quality of your own report and also looking at the quality of your opponent's report. So let's have a look at those duties in a moment. But when one's looking at one's own report, or indeed the other side's report, one's looking to see, is the content within the expert's expertise? Is it based on the expert's knowledge? Are those facts correct? Where facts, examination, tests, and so on have been carried out by others, has the expert set out from whom and set out the extent to which they participated in obtaining the facts and material in question? Where there's a range of opinion, Have they summarised it? And we'll come to that in a moment. Where there are material facts in dispute, have they given their opinion on each hypothesis? Is the opinion based on an unjustified assumption? Is it based on flawed data? These are all questions which, when I'm working through an expert report looking to undermine it in cross-examination, I'm working through these questions. I'm looking at the report and building up lines of attack to expose that these questions do not have favourable answers for my opponent. It's very common, and I'm sure you've seen it many times, that experts don't understand the correct legal test for negligence or the correct standard of proof, or at least they don't address those questions sufficiently. So one's always got to pay close attention to those points. Now, weaknesses in the report, as I've suggested already, the key ones are those on the screen. Let's have a look at an example. In the history in a report, it says this: the claimant said her back pain got a lot worse after the accident. The opinion, in my opinion, it was the index accident that caused the resurgence in back pain. What we know from the background of the case is that at the same time as the accident, in the rest of this claimant's life, she had increased physical demands at work, she was getting divorced, she was moving house, and she mentioned all these to the GP in relation to back pain, but did not mention the accident at the time. So in a report that simply forms that view, without necessarily weighing in the balance these other points, one can immediately see, and it's a simple example, but it's common in more complex cases, we can immediately see difficulties with the conclusion. So here we have question: is the opinion based on facts within the expert's knowledge? Are those facts correct? Well, in this case, we know that there are other facts that might play in the expert's opinion. Where there are material facts in dispute, has the expert given their opinion on each hypothesis? Well, we'd have to say that certainly in this case, there are other facts that haven't been brought out in the history and that possibly the claimant didn't mention during the consultation. Has the expert dealt with that? No, they haven't. Where there's a range of opinion, has the expert summarized and explained why they've reached their conclusion? Well, here we can anticipate that there would be a range of opinion based on the other contemporaneous issues in the claimant's life. And this expert hasn't summarized those facts and hasn't summarized the range of opinion that may flow from those facts. Is the opinion based on flawed or incomplete data? Well, it's certainly based on incomplete data. And these questions that we're posing about this opinion are exactly the sort of questions, of course, that the other side will be posing and drawing on to construct cross-examination. But equally, I suggest, they are the sorts of questions that we should all be asking ourselves about this opinion if it is our own expert's opinion. And don't we want to take some action to try and improve what the expert has said? I mean, on the face of it, of course, it's hugely supportive of the claim, but actually, wouldn't we be better off at suggesting to our expert that he or she ought to weigh up these other contemporaneous issues to set out that there may be a difference of opinion as to the range of opinion, and to thereby insulate our expert as best we can from damaging lines of cross-examination or questions, Part 35 questions, or arguments raised in joint statements and so on. Now, this quote from a case of Dingley and Chief Constable of Strathclyde Police is one that, in my view, one ought to have tattooed onto well, if not the expert themselves, maybe their instructions, because really what you want from your expert is reasoning, not just the conclusion. And it's surprising how often experts do not set out their reasons for reaching their conclusions. And I'm always looking when I'm analysing reports for the reasoning, and suggesting to experts in conference and so on that I would like to see more by way of the reasons underpinning their conclusions. So we've identified some weaknesses in our little example with our expert. And the next question is, how does one remedy these? And this really is the skill of the lawyer in bringing out your expert's opinion. And it is an area where we encounter great tension, because we've got on the one hand the need to respect our own professional duties, not to coach our expert, not to overstep the mark, and not to write the report for the expert. And yet, on the other hand, we have immense frustration where we may have an expert who has persuasive opinions but hasn't expressed them particularly well. We may have an expert who's a fabulous clinician but is simply not as competent as we'd like in writing a report. And of course, experts are not lawyers. They're not skilled in forensic drafting and making sure that they set out the premises and that the conclusions follow those premises. So it is a difficult and somewhat challenging job to move our expert report from a position of being underwhelming in its reasoning or its construction to one where it's robust and we feel confident. I have found recently one of the benefits to come out of the pandemic is that experts have been more readily available on video link, on Zoom and so on. And I find that making contact with the expert as a human being in the first instance is hugely beneficial. You can't coach your expert. You don't want an expert who's overly favourable and has become too personally attached to the case. But you do want an expert who's bought into the case, who feels a sense of responsibility for the opinions they're giving. And one way I would suggest of improving that relationship is to meet over video link. The days of meeting in person seem to be diminishing even before the pandemic, and quite often, certainly acting for the government, as I frequently do, they wanted to keep costs down and simply have a telephone conference with the expert. But in my experience, they're not as effective in terms of building up that rapport, and certainly not in a recent case where my expert had decided to join the conference in the back of a taxi whilst going through the Blackwall Tunnel. So I would encourage all of us to try to get the experts onto Zoom. It didn't work so well with my aged expert that I alluded to earlier on, who was sitting in his kitchen and was struggling with the video link. But most experts, of course, will be very familiar and able to join by video link, and I would suggest that ought to become the norm. Because it's so helpful in building up rapport and getting your expert on board with the task of redrafting or adding in the detail that you're seeking. I tend to send an agenda, even if it's only a short one, to experts before a call. I think they find it hugely helpful. It helps focus their mind, and it helps them to know they're not going to be hauled over the coals or questioned about other areas. They know what it's about. And then that agenda can form their aid memoir as you're taking them to the various elements of their report that you might want them to add detail to. And after the call, very often I set out a short bullet point addition to the agenda of the key points that were discussed and the paragraph numbers where it had been agreed detail could be added. Because, as I'm sure you've all experienced, you can have an incredibly successful conference with your expert. You feel that you know exactly what's needed. You think you've communicated that to the expert. And unfortunately, they go back to their busy clinical life, and what you get back is not as well drafted as you'd hoped. And it is a frustrating process, but they do tend, in my experience, to produce better second drafts if they've got something in front of them to help them remember what it was they said during the conference. Now, there's some slight bit more detail on the slide there. It delves into help that your expert can give you in undermining the other side, and particularly in terms of scientific papers and so on. They featured reasonably heavily in the Kenya case, and we spent a lot of time reading scientific papers and getting our experts to assist us in distinguishing them in the same way that you do with a case. And then really central question is your expert actually struggling to help you, and is that because there is a fundamental problem with your case? It's better to ask your expert what are the strengths and weaknesses of this case and get those out at an early stage. Now, joint statements, just in the last few minutes, again, more complex cases, of course, you'll have an agenda, but it's worth reminding ourselves that this ought not to be in the form of leading questions or hostile in tone. It is aimed to bring out the central points of the expert's opinions and to address what it is the judge needs assistance with in the case. I was recently sitting and in a CCMC, there was a joint statement from two neurologists that ran to some 30 pages. The level of detail was extremely impressive, but also in many ways very unhelpful. The task of the judge is a difficult one, and that report is not the only piece of evidence in the case. And to have to grapple with a 30-page joint statement is, I would suggest, going to put your judge offside even before he or she starts. And really it's for the lawyers to take charge and to get that joint statement down to a manageable size. And here's a little bit of dicta from Mrs. Justice Yip, where she reminded the parties in the case of Saunders of the importance of the joint statement, and that it be possible to read it and understand the key issues and each expert's position on those issues. Sometimes less is more as far as the agenda is concerned. I mean, it's no surprise that judges want manageable amounts of information, and it simply is unhelpful to overwhelm the judge with irrelevant issues. There's some helpful, I think, dicta from Mrs. Justice Yip, reminding us all of the need to help the court in focusing our experts on the key issues. Now, it's rather worryingly, you might see the word quiz there. In fact, that's just a signal to me to check the time, to make sure that I've not overrun or underrun, and I see that actually I'm pretty much bang on 1/2 past. So I'm not going to burden you with another quiz. I'm going to stop there and hand over to Luke. And if you've got any questions that come to you, do pose them in the chat function. All right, Luke. Oh, I better stop sharing my screen. Just a second. Luke, has that stopped sharing?
It has, thanks, Richard.
All right, over to you.
Right, bear with me just a moment while I switch to my screen instead. Right, that should be better now. Sorry about that. I'd say it's nice to see so many familiar faces and to see some familiar names as well. My task today is to talk to you about chronic regional pain syndrome, which is often a perplexing subject when it comes up in litigation. And what I'm intending to cover with you today is how does CRPS come up in litigation, which you'll probably be familiar with, so we'll cover that briefly. What is and is not CRPS? How CRPS is diagnosed, the kind of treatment that the experts have in mind for CRPS, And then I'm going to direct you to some further reading, in particular, the Royal College of Physicians guidelines, which are extremely useful. So, how does CRPS come up in litigation? What does it look like? You're probably familiar with this type of scenario. Your claimant suffers a relatively minor injury. It's often a fracture or some sort of injury to the limb. The claimant doesn't recover within the prognosis given by the orthopaedic consultant. The orthopaedic consultant says they can't really explain what's going on from here. There might be a chronic pain issue, but basically they're at the end of their expertise in terms of what's going on. They may well recommend a rheumatologist or a consultant in pain medicine or a psychiatrist or psychologist, or potentially all three of those. And you are left really trying to determine whether there is a genuine injury here, what it is, and what you do with it in terms of valuation. So the aim of this talk is really to try and stop you looking something like this when chronic pain issues come up, or CRPS in particular. So let's look first of all at what CRPS is not. So there is, of course, a distinction between chronic pain and CRPS. Chronic pain is simply any pain that lasts for more than 3 months. That's the way that the International Classification of Diseases makes the distinction. Anything more than 3 months is chronic, anything less than 3 months is acute. So it's very, very common that your pain consultants will say that there is a chronic pain issue. That doesn't mean that you have a chronic pain disorder. That doesn't mean that there is CRPS. It just means that it lasts longer than 3 months. And I think that is sometimes something that's not always appreciated. CRPS, as you will know, is a rare condition, and it does require specific criteria to be fulfilled, and we're going to have a look at those in a moment. There are other pain disorders as well. They're outside the scope of this particular presentation. I think if I was to do a talk for you covering all of these, it would probably be a whole day talk rather than a half an hour one. I put some examples of fibromyalgia, conversion disorders, somatic symptom disorders, and chronic fatigue, for example. They're not CRPS. And CRPS is quite distinct from malingering as well. So, in terms of what is CRPS, CRPS is a chronic pain condition, and it does normally follow injury to a particular limb. It's normally a distal limb, so arms, legs, at the far end really that you're generally talking about. There is clinical research, and that defines CRPS. The best summary, I think, is probably Veldman's example in the Lancet from '93. And I've put that there on the slides for you. It's a debilitating, painful condition in a limb associated with sensory, motor, autonomic, i.e. related to the nervous system, skin and bone abnormalities. The ICD also defines CRPS. You've got the definition there. I'm not going to read it out, but you'll take a moment just to read through it. The key thing with CRPS really is there are often visible signs. The edema, as mentioned there, the swelling, the skin, blood flow, motor symptoms, and so on. So there is a definition there. Although the ICD says it's preceded by a noxious event, we're going to come on and have a look at that in a moment or two. The JC guidelines offer a definition of CRPS. It's woefully inadequate, in my opinion, and is well short of what we're going to cover today, and well short of what your experts will be looking at when they consider this. CRPS is diagnosed using the Budapest criteria, which we're going to look at in a moment or two. So there are two types of CRPS. It doesn't actually make any difference whatsoever to the treatment of it, but there are two types. Type 1 involves no nervous injury, essentially. Type 2 involves damage to a nerve, a major nerve. So they're the two types, so it doesn't make any difference to treatment ultimately. What is CRPS? Well, there are some further facts about CRPS that can be found in the Royal College of Physicians guidance that I referred you to earlier, which is a particularly useful document and source of information. And there are some interesting things to take away from that. Obviously, I'm not a pain expert in terms of a medical expert, but I do a lot of pain cases in practice and on the bench. And so I've got a fair bit of experience in it, but obviously this is only a bird's eye view. Even with that experience, your pain experts are really going to be the people you're going to need to talk to if you get cases about this. But there are some useful things to highlight to start with. As I say, it commonly arises after an injury to the limb, so not uncommon in a PI case that you might be facing something like this. The research shows that precipitating events are fractures in 45% of cases, sprains in 18% of cases, sometimes surgery, 12% of cases, but in around 9 or 10% of cases, there is no precipitating trauma. Obviously, that's not exhaustive, but you're looking mostly at fractures, sprains in terms of what's going to precede CRPS. Immobilization is a factor, and so often with arms where you've got a sling or and a limb that's not being moved around particularly, that can increase the risk factor for CRPS. For the majority of cases, there's onset of symptoms within a month. And it bears absolutely no relationship to the severity of the initial trauma. So you can have quite a modest injury, really, and quite significant CRPS. It does normally affect just one limb, but in a minority of cases, the research suggests 7%. It can spread to other limbs as well, so you can end up with CRPS in a completely different limb from the area originally complained of. It's a very rare condition, CRPS itself, about 1 in 2,000 population prevalence. It's much more common in women than men, 3.5 to 4 times more common in women. And it's much more common in upper limbs by a ratio of 2 to 1. Chronic regional pain syndrome is often thought about as something that really never goes away, but in fact, 75 to 80% of people actually recover from it. The difficulty is those that recover from it tend to do so quite quickly. There are 15% that have unrelenting pain at 2 years, and the prognosis is pretty poor for them. And one of the reasons for that is because early treatment is a massive positive indicator for CRPS. And that's often not diagnosed within 2 years because it's such a difficult disease to diagnose. So as I say, prompt diagnosis and early treatment are best practice, but just because of the amount of time it takes to realize it is CRPS, you're often beyond that. Chronic pain is associated with high levels of anxiety and depression as well, so it is often an interplay between your psychiatrist's views and that of your pain consultants principally. So what actually is it? As I say, it is something you can often see. Swelling, sweating, colour change. I've put up a picture there of CRPS in a distal limb in respect of the leg. You can see the difference in colour. You can see this swelling there. And so it is sometimes quite obvious. Not always, but sometimes it can be obvious. The diagnostic criteria for CRPS has changed significantly over the years. We used to use the IASP criteria. That has been consigned to the dustbin, really. And since 2003, the Budapest criteria are used that I mentioned earlier. Budapest criteria are universally accepted by the medics, but the criteria don't always result in a correct diagnosis. They're not infallible, essentially. They do produce less false positives than the 1994 criteria, but it isn't entirely infallible. So here are the Budapest criteria. 4 elements to it. The patient has to have continuing pain, which is disproportionate to the original event. The patient, presuming there is an original event, which is why it says any inciting event. The second limb is that the patient must have at least one sign in 2 or more categories that we're going to look at in a minute. By a sign, we mean something that the doctor can physically see. So this isn't self-report. The third limb is self-report, so the patient themselves has to report one of 3 of the categories that we're going to look at a moment, and no other diagnosis can better explain the signs and symptoms. So CRPS is a diagnosis of exclusion. You have to rule out everything else, and at the end of this talk I will show you some of the other things that are often in play from the RCP guidance. So you do have to exclude those, and that is why it often takes so long to actually get a formal diagnosis of CRPS. So let's have a look at those categories that I referred to in B and C. So the signs that the doctor's looking for and the self-reported symptoms, they're laid out for you there. So sensory, first of all, essentially, for example, if you touch it, there's a completely disproportionate pain reaction. That's what you're really looking for. Vasomotor category is temperature asymmetry. So you've got a difference of more than 1 degree between one limb and the other limb. Swelling and sweating changes is the third. And in terms of the fourth element, it's motor changes, the motor dysfunction, weakness, tremor, or trophic changes, which can be in the hair, nails, or the skin. So diagnosing CRPS is really quite tricky, and there are a number of problems that arise in terms of litigation and CRPS. The first one, main problem, is that experts who aren't specialist enough make the wrong diagnosis. You get, as Richard was saying earlier on, experts who this isn't really their thing, and they start meddling in it, and you just have to disregard their opinions, really. You really do need the right experts. The pain consultant is really the person who's going to make your ultimate diagnosis on this. The experts are often more concerned with simply treating the person in front of them than they are with diagnosis. So the difficulty often is that naturally medical experts want to treat the patient. That's their job in day-to-day life. So they're looking at, well, this could be done, or this could be done, or this could be done, but they fail to look at what the actual diagnosis is. They fail to go through that reasoning that Richard was talking about earlier. And we need to make sure they do that in their expert reports. They often don't address the balance of probabilities, so we need to remind them of the correct test. It's very common that they'll put things in really quite vague terms in pain management because they're a bit less certain, and you have to figure out whether they are simply less certain or whether they just haven't phrased it very well. Some of this can depend on subjective symptoms that the claimant reports, and they're vulnerable to cross-examination on that, so you will definitely need to make sure you've had suitable conferences with your clients on a case like this, because they can research things online and sometimes just say the right thing, consciously or otherwise. In my experience, if you're really going to get to the bottom of it, you normally need to have a conference with the experts, because normally one of them is not necessarily willing to go out on a limb on a CRPS diagnosis. Some pain experts will, but they'll want to get together with the others. So you'll often have a conference with your pain experts, your rheumatologist, your psychiatrist, and counsel to really get to the bottom of what the final view is. And also, that's an interesting dynamic in terms of a conference, because you'll be able to see which experts are going to defer to others and who's really going to carry the day when it comes to a trial, if you need to go to a trial. Pain consultants do, in my experience, fall in two camps. They tend to be hawks or doves. They tend to be more claimant or defendant minded. Obviously, you want to try and find somebody that's even-handed, but there is a difference, and you have to be a bit careful there. As I say, it's generally not a straightforward diagnosis, so there's plenty of room for a range of opinion, and you really must get your experts to cover that, so that, as Richard said earlier, they're not taken by surprise or vulnerable to cross-examination at a later point. Some things to consider when you're dealing with these types of cases, or to watch out for. Photographs. Consider photographs. They can be really very useful because you can see the changes, as I outlined earlier. Be wary of the recorded consultations, particularly defendant experts will often, pain experts will often want to record the consultation. You may find it doesn't really accord with your expert's examination. I'm going to just dip to one of the other points here, and you may often find that surveillance has been undertaken often on the day of the examination itself, so as to show any differences between what they're telling the expert and what they're actually doing. You do have to consider other potential diagnoses, and experts that don't do that are not going to be very good, because there are so many other potential diagnoses, potential of malingering. The expert is going to have to deal with that and say why they don't think that is the situation here. As I say, a conference can be very good. Also, one thing that's very helpful is look out for corroborative notes. Problems that occur in the medical notes within a month of the incident, look out for immobilisation, look out for trauma to that particular limb or pain in a particular region. All those things are going to help your expert when it comes to diagnosing this. And if you're at a stage where you haven't got your expert's reports and you're thinking, well, what am I going to do with this? It's helpful to look at that because you're going to know they're the things that they're also looking at. Early treatment, if you're fortunate enough to be in an early stage, see if there is any early treatment that can be arranged for your client, because that's going to make a really significant difference. And be aware of offers and risks as always, but particularly in these types of cases, the range of opinion is so wide, there's quite a lot of risk. There is often issues of fundamental dishonesty floating around in these cases. They need careful consideration. And the claimant needs to be properly advised of all of the potential risks that they face in dealing with this litigation. The defendant's going to have those in mind as well. In terms of treatment, there are 4 ways of treating it if it is ultimately diagnosed as CRPS. I've stolen this particular diagram from the RCP guidance, which is really the leading document on this. There are 4 pillars to the treatment. The first one is physical and vocational rehab, often a pain management clinic. The second one is psychological intervention, because there's a big overlay between the two. Pain relief, medication, and information and education. So in terms of treatment, what are we looking at, and what are the things that will make your ears prick up when dealing with CRPS? Well, medication itself, amitriptyline tends to be a first line, gabapentin, pregabalin, duloxetine for neuropathic pain. If you see in medical notes gabapentin or pregabalin, immediately you need to start asking questions. Those are not first line drugs, and they are very often prescribed for CRPS or for other pain disorders. So it might be a different pain disorder, but they're not first line. Somebody will have had to have been involved with the claimant or patient in quite some way, really, in order for them to be prescribed that. And there probably has been some kind of involvement with a pain clinic if those types of drugs are being prescribed. There are normally antidepressants involved, sometimes anticonvulsants because of the tremors and so on. So look out for those and consider those. Drug infusions are another way of treating it, one additional way. Injections, the nerve block type thing is really is another area where treatment is common. The aim is to break the cycle. So you've got this fairly unpleasant cycle for sufferers of CRPS. They've got the physical pain, and then they've often got mental health difficulties too. And the two feed into each other. And if the cycle of pain can be broken, sometimes the CRPS can be resolved. So the nerve block just gives them enough of a break that they're not suffering the pain, that their mood improves, and things start to go in the right direction. Some of the more recent treatments are things like spinal cord stimulation. I'm going to send you the NICE guidance in relation to that so you can see when that is recommended. A very, very common area is the multidisciplinary pain management program. So that could be residential or non-residential. Your client goes and gets the CBT, they get the pain management experts, they get the psychiatrists and psychologists, and they all work together. The downside can be that often a pain management program won't take a claimant who is undergoing active legal proceedings because it's a negative prognostic factor. There is some further information in Appendix 13 of the RCP guide in relation to that. Psychological treatment is obviously something that is on the radar. There are some more extreme treatments, and you will probably need to be aware of these because people who suffer with chronic pain conditions have often exhausted numerous medical experts, both potentially medico-legal and treating, and they will have done a lot of research normally about where else you can go because they're in a lot of pain and they want to know how to deal with it. And so they are more open to considering the more extreme treatments. And so some of those can be amputation. There is specific guidance in the RCP guide as to when that's done and the downsides, obviously. And you have to be aware that even after amputation, payments can still be left with CRPS at the stump. They can have phantom limb pain, and it doesn't stop it from spreading to another limb. As I said earlier, 7% of cases go to another limb. You can imagine that medics are incredibly reluctant to endorse this in most cases, and wanting an amputation can also be part of the actual CRPS itself. So you have to be very cautious on that. Ketamine coma is another newer treatment, as well as ketamine infusions. There's some more information in the guidance on that. There is published research on all of the experimental treatments, and it can be found in Appendix 15. So if you are facing a case that involves these sort of more extreme treatments, then have a look at the published research, because you'll be able to see what your experts are basing their views on, and they're really good sources for questions to the opposing experts. Some final points to consider is you will need to refer to your experts, so it is really important that you know them and that you know whether they are truly expert in this. Pain consultants can specialise in different things, but they're generally going to be the person you go to. Rheumatologists as well, but you really are going to need to know them, because they are going to be the people that carry this case for you. If you're going to succeed on this, it's going to be them that's going to have persuaded the judge of the diagnosis. Early treatment, as I say, is key, but it's often too late. There are specialist centres in terms of treatment that deal with CRPS. They are found in Appendix 8 of the guidance I'll send to you. Locally for you, Bath is particularly well known, and that's the centre you'd probably be thinking of if you had a local client. NICE are also developing new guidelines in terms of how you assess and manage chronic pain as a whole. They're not out yet, but I've put the link in there for when they are due to be out. The committee responsible is being chaired by the two consultants I've mentioned there. I mention them because it's useful to know who's at the leading edge of these things, particularly when you're thinking about which experts you might like to instruct. So that's a bit of a whistle-stop tour on CRPS, and the aim is to give you really the resources you need and the pointers you need in terms of where you go when you get it. The other thing I said I would show you was the RCP guidance, so bear with me a moment while I just switch screen shares. So earlier on, I spoke to you about the RCP guidance, and I said that it is a diagnosis of last resort. And the RCP guidance itself includes a number of other very common diagnoses that need to be considered when thinking about CRPS. And I'm just going to put those up because I think it's useful just to see the kinds of things that are being talked about. So this is the extract from the guidance. And these are all of the things that should be being considered because they are what they call differential diagnoses. So the pain could be being caused by any of these types of things instead. Some of them are straightforward: joint instability, infection, so on. Raynaud's disease, not so straightforward. There are an awful lot of things to exclude, as you will see, and these are all meant to be excluded before getting to a diagnosis of CRPS. So your expert's going to need to cover these and cover why these are not the correct diagnosis and why CRPS is. So bear that in mind when you are looking at it. That's page 13 of the guidance that I'm going to send you. It is a really useful document, this one. Let me just show you the broad measure of it. When you look at the contents pages here, there's guidance about that touches on each speciality, so primary care, OT, surgical practice, emergency medicine, rheumatology, dermatology, pain medicine, rehab medicine. Some really useful guides here. Long-term support for CRPS, and the appendices are excellent as well, and perhaps not the commercial sponsors section, but there are some really useful things in here about desensitization, the centres with specialist interests, the general risks of amputation, and there's some really useful appendices towards the end about patient information. So there is information that's given to patients about CRPS. There's information given to GPs about CRPS, Appendix 3, just here. an information leaflet. These are really good places for you to start in terms of getting a proper understanding of it. The references and the glossary are particularly useful as well in terms of research. And the useful thing you've got here is all of the leading experts are listed because they're part of the panel. So these are people you may well know. People like Professor Atkins on the orthopedic front is a real leading expert on the orthopedic side of things. But Chris Barker, the clinical director of pain medicine, well known in this area. So I'm not recommending any one of these in particular, but you will be able to look through here and think, well, there's a good place to start in terms of the experts that you might want to consider. Because if you don't get them, the defendant may do anyway. And there are people who really are leading the field in this, and you don't want to be outgunned, essentially. So there is an awful lot to say on CRPS. I can't really do it justice completely in half an hour, but I hope in any event what I have done is highlighted the main sources of information and some of the main things to look out for, and perhaps given you some pointers for the cases that you might have. I will send on to you the RCP guidance that we've just looked at there. I will send on to you some guidance from the Pain Management Society, for those that want to do some more reading, and I will send on to you the NICE guidelines as well in terms of spinal cord stimulation. So you've got those things. You don't, obviously not going to necessarily read them now, but you've got them in the back pocket. When you get something really serious come up, you can look at it. Obviously, it's quite important to get the diagnosis right if we can, because the impact on special damages can be quite significant, as well as the impact on work. You may well be in a situation where you could be looking at lifelong loss of earnings for more serious cases. So that concludes everything that I had planned to say to you. I think Richard and I are both happy to take some questions, or be it questions that relate to specific cases. Will probably need more in-depth discussion than simply a couple of minutes here. So if there is anything you want to ask, do feel free to kind of unmute or share your question in the chat section.
Thanks very much, Luke. Really, really helpful. I hope you've all found it helpful on these two topics today, and do unmute yourself and say hello if you'd like to. We're very keen to hear, I think, if you've got any thoughts after the call in terms of either just how we've delivered this, just in terms of the practical issues of the PowerPoints and so forth, or in terms of anything that you think would be useful or interesting to hear in the autumn, or any other feedback. I think probably you've got the link. When you got the link, you'll have seen Dave Snook and Lisa, who's in charge of marketing. They're very willing to filter for us the abuse. So anything, any sort of awful comments about our delivery, we don't see that. So we live in this wonderful bubble of thinking that we're brilliant. And feedback is always welcome, particularly nice feedback. But actually, quite seriously, any topics that you think lend themselves to half an hour over Zoom in the autumn, we'd be very willing to speak on and do the research and save you some legwork and get something going again in the autumn. So there we are. I mean, we've kept it to an hour. Does anybody want to say anything, or even if it's just hello to your colleagues, waving to them across the awfulness of Zoomageddon? Well, you're all being very reticent, which is absolutely fine, because the thought of having to field a difficult question is always one that fills me with dread. But I hope you found the cross-examination useful. Luke was pointing out to me that that the only time I've ever done a successful cross-examination is when it's been scripted out and I knew what the answers were going to be. So I enjoyed it because it was successful from that perspective. All right. Well, look, I don't think there's much else. I don't see people clamoring to join in. I wish we could meet with you and we could have a drink afterwards and all the things that we that we like to do, and I do hope that we get to do that again soon. I see Mark's raising a glass there. Yeah, well, it's pretty early, but I've just had my family come back, so maybe I'll be with you in just a few minutes.
It's after 12.
All right. Well, it's been a delight to see you all, and I hope you keep safe, and I hope some of you might even be having a holiday soon of some description, whatever the government allow us to do. I'm hoping to get to France before they change the rules, and then I should be keeping my head down. All right. Well, I'm going to say cheerio. What do you think, Dave? Is there anything else new? You're on mute, Dave, if you wanted to.
No, I think you've covered it all, but yeah, just to go with what you said, and thanks everybody for taking the time to join us.
Cheerio.
Thank you very much.
Thank you.
Okay, bye.
Thank you. Bye.